Hi guys, welcome back to the channel. Let's start today's class. Okay. First term is Odontoameloblastoma. Okay, this is not the variant, but this is the subtype or not also a subtype. Just remember this is something there in ameloblastoma. Odontoameloblastoma, clinical presentation and pathogenesis. It is an extremely rare odontogenic neoplasm. Represent an invasive ameloblastoma occurring simultaneously with an odontoma. It is a type of invasive ameloblastoma, but it also has the features of odontoma, or it occurs simultaneously with an odontoma. It is mainly odontoma plus ameloblastoma. Okay, so it is also known as collision tumor. Ameloblastic odontoma often used, but it should not be used. It is not ameloblastic odontoma, it is odontoameloblastoma. It is present as a painless jaw expansion. Radiograph shows a multilocular mixed radiolucent and radiopaque lesion. It can be multilocular or unilocular, and it shows mixed radiolucent and radiopaque lesions. Okay, the odontoma component is complex type. Okay, we know that odontoma can be compound or complex. It is in this odontoameloblastoma, the odontoma component is complex type. Occur in molar ramus region. Incisional biopsy is required and may take the form of enucleation of soft and hard tissue from bone. Okay. After diagnosis, a CT scan to assess the extent of tumor. Histopathologically, the epithelial component is identical to that of ameloblastoma, and the presence of ectomesenchymal component with the formation of dentine and enamel. This represent odontoma. So, it is a result, a mixture of ameloblastoma and odontoma. What is the treatment? Treatment is resection using 1 to 1 centimeter bony margin and 1 uninvolved anatomical barrier margin. Okay, 1 to 1 centimeter of bony margin and 1 uninvolved anatomical barrier margin. Okay, this is all about odontoameloblastoma. When you write about the clinical variants of invasive ameloblastoma, just mention this. Okay. Now coming to odontogenic carcinoma. Okay, they are of 4 types. They are also again of 4 types. We will dealing with the first type today. First is primary intraosseous carcinoma ex odontogenic cyst. Clinical presentation and pathogenesis: present as an uncomplicated dentigerous cyst. It also may be present as a dentigerous cyst in which the radiolucency shows an irregular demarcation to the adjacent bone. Presence of decreased sensation or paresthesia is a suspicious sign suggesting malignancy. Occurs mainly in older individuals, like older than 50 years. Residual impacted tooth develops an expanded follicle appearance or seems to develop a dentigerous cyst-like radiolucency. Since it is in older individual, so there is a residual impacted tooth. Histopathology: this tumor is essentially an odontogenic cyst in which an invasive carcinoma arises from the cystic lining. Rare occurrence: collision between a carcinoma and cyst must be considered. Cystic lining is dysplastic, obviously, as it is arising from the cystic lining. Carcinoma is squamous in nature and invade the surrounding tissue. All the regional lymph node and distance metastatic potential of mucosal squamous cell carcinoma. Okay, there is a regional lymph node involvement and distance metastasis. Okay, This is all about primary intraosseous carcinoma, exodontogenesis. The main thing is it arises from the cystic lining of the odontogenic. The carcinoma arises from the cystic lining, which is dysplastic in nature, and it is a collision between a carcinoma and cyst. Okay, that's all for today. Next class we will be dealing with the other three odontogenic carcinoma. Till then, like, share, subscribe and comment. Bye.